So today's presentation, I'm going to go a little fast because it's sort of the end of the day, and I want to make sure you all get out there and get your daily steps in. 7,500 steps per day is the goal. Used to be 10,000 steps, but I guess they figured out that you could, kind of cut it down to 7,500 and still have the same cardiovascular benefit, which is good news for some of us that can only get 7,000 steps a day in rather than 10,000. So today's presentation is split into two parts. It's firstly to give a overview of kind of in the trenches clinical considerations about dementia care, and then how we can perhaps make it better. And then with Rebecca, we'll be giving more of a 30,000-foot view of how states organize their plans for dealing with this incredible growth in dementia throughout each state and certainly throughout the country. So the goals are to ask how healthcare providers can become leaders in dementia-friendly healthcare. People are talking about dementia-friendly healthcare. They're talking about age-friendly healthcare. They're also talking about dementia-friendly communities. So these are all terms that are resonating with those of us that are interested in doing better over time here. So this, I think many know, is that as you get older, you have an increasing chance of getting dementia, whether it be vascular, mixed, Alzheimer's, or other of the dozen or more different types of dementia. And it's really now advanced to behind cancer and cardiovascular disease is now one of the top causes of death. And, it used to be that people didn't document on the death certificate Alzheimer's disease or dementia. And now that people have figured out that loss of memory is not normal aging, healthcare providers are now actually being a lot more accurate with their death certificates. And so that's why we're seeing the prevalence increase so dramatically. Sorry for the little blurriness on the slide. That's what happens when you find something on the internet, but this was a good one. It kind of listed the risk factors on the top and the protective factors on the bottom. There's a study out that shows that meat-forward diets, particularly red meat, cause hippocampal brain atrophy. The MIND study and the Mediterranean diet studies all reveal that vegetarian-forward diets are protective. Also, importantly for lifespan. So the Adventist study showed that vegetarians on average live 8 years longer than omnivores. And that's an important consideration because if you do anything to prolong the lifespan, you then also delay chronic conditions that might come along with older age, such as Alzheimer's disease. So just from a perspective of a healthcare provider, there's an awful lot of patients and that just aren't recognized as having any type of memory loss whatsoever who actually have memory loss. And it's worse in rural areas than it is in urban areas. And that's part of our mission with Dr. Manoj had mentioned about our geriatric workforce enhancement program in the Dakotas. One of our missions is to really help improve the understanding. I think there's a fait accompli that occurs amongst providers because they say, well, if I detect, memory loss, what am I going to do about it? And so there's just kind of this sense of hopelessness. Also, by the way, my first experience with patients in North Dakota when I moved up from Chicago was that I was going to be a good geriatrician, and so I was doing the memory testing along with, just regular clinical practice. And boy, did I get this one patient who was just complaining like heck. She says, "Who is this Dr. Jurivich? He comes in and, he starts testing my memory. And all I came in is I just wanted somebody to fix my hip." And so she was not too happy that I was testing her memory. She did perfectly fine. But again, sometimes providers might be a little reluctant to test memory because, it might be a little bit of a challenge, with their patients who may not just want to know, just like some people don't want to know they have cancer. So it goes in that sort of provider patient relationship consideration. I list here a variety of ways that you can screen for memory disorders, these self-reporting. So we're piloting the 88 in a pharmacy, a community pharmacy, to see if people can self-identify with memory loss. In the clinics, probably the best, highest sensitivity and specificity is the mini-cog. And we were talking about laughter. The mini-cog also provides a little bit of entertainment from a clinical setting because you get some very interesting clocks drawn, and we'll talk about that. You want to ask in the history if there were firstly any memory concerns, and that's a good icebreaker for approaching patients about that. If you notice that they're searching for words, that was what happened in the second term of Ronald Reagan's presidency. You might suspect that there's some memory loss going on. And then a variety of other things that you might look at here as part of the a more detailed history. In terms of the physical exam, just kind of the skinny on this is that I tend to look for issues with upward gaze paralysis, which might be associated with a neurodegenerative condition called progressive supranuclear palsy. Tap on the lips, and if they pucker up, that could be frontal release signs associated with frontal temporal dementia. Cogwheeling is always important to detect both for Parkinson's disease as well as Parkinson's syndrome or stroke. So if you have a unilateral stroke, sometimes the midbrain gets affected and you'll have some cogwheeling. Tremors and fasciculations are a little bit more deeper dive into things like Creutzfeldt-Jakob disease and other neurodegenerative diseases. I tend to do vibratory sense. It is decreased with aging, particularly in the feet. But if you have bilateral or in upper and lower extremity loss of vibratory sense, you need to think about conditions such as heavy metal toxicity and certainly vitamin B12 deficiency. So I mentioned the mini-cog, and these are different examples of the clock draw. You see different arrangements here, and not to get into too much detail, but the way people draw clocks can sometimes reveal what parts of the brain are not functioning as well. The mini-cog basically is three-object recall. You have to make sure there are different categories. So you go apple, flag, car. You don't go woman, man, people, as we had seen in previous presidential cognitive tests, because you want the categories all to be different. And then the clock draw is also helpful to seal the deal as to whether they are cognitively intact or not. If the patient is disinclined, for doing the mini-cog, you can try and have them name as many animals as possible. And for those that were earlier this morning, they may have heard my story about a patient I just saw the other day who got stuck with naming more animals, and he stopped at snake, and then he said snakes, and then he said more snakes. So he kept escalating the number of snakes to try to fit in more animals. So I thought that was pretty clever. We tend to use the SLUMS test, the St. Louis University mental status test, and it's the same score as the MoCA test and the MMSE. So the primary consideration, so you can get normal tests on all those screening tests if the individual has loss of executive function, if they can't plan, they can't execute a plan and get to the finish line, that could indicate loss of executive function. And that's the primary element that goes into the diagnosis of dementia. Not going to mention too much about blood and other tests, just basically we look for reversible causes of thyroid disease, B12, and if you're diabetic on metformin, you probably should get a folate test too. In terms of brain imaging, I want to just mention that there are differential diagnoses, and so you can see on the left corner here that somebody has a tumor that might be associated with memory loss. In the middle is dilated ventricles associated with normal pressure hydrocephalus. And I believe we had a Wheel of Fortune game or a Jeopardy game where we asked for the three things that constitute normal pressure hydrocephalus. And so is wild, wet, and wobbly are the clinical signs of NPH. And then you can see on the right-hand slide here, this upper area of density that represents a subdural hematoma. MRI scans, maybe not needed so much, unless perhaps more on the West Coast, people will diagnostically look for hippocampal volume loss over time as a predictive measure of progressive dementia. And then other tests. So people that have high educational levels tend to need neuropsych testing to do a little deeper dive into their components of memory loss. Brain biopsies are done rarely. EEGs are done rarely. And those are more associated. The EEGs, the encephalograms, would be more linked to people who you think are having temporal lobe seizures. So I mentioned there's 13 types of dementia. So sometimes it's important to try to delineate what's occurring because there are differences. So for example, Lewy body dementia is not very responsive to antipsychotics for behavioral management. In fact, it may make it worse. So that's why it's important to have the right diagnostic label, if you will. Just want to briefly go over some of the treatment options. So here's a list of everything that's going on as we know it for treating Alzheimer's disease. And you may be hearing a lot more this week, in fact, about the monoclonal antibodies that lecanemab for treating amyloid. And the idea is that the antibodies that you're given from these, there's three of them, there's three different monoclonal antibodies. So it's immunotherapy. And the idea is that you're trying to clear the amyloid out of the system, but that's all based upon a hypothesis that amyloid is driving Alzheimer's disease. And you can see here that neurofibrillary tangles or inflammation of the brain are other theories about why we get Alzheimer's disease. And there's some, I think, earlier discussion with our dental expert talking about the oral biome and what relationship that might have with inflammation and being a co-stimulant of dementia. Some people also talk about chronic sinusitis as also being a nidus. And then most interestingly is all the data, and Dr. Minocha can actually attest to this, is about what the relationship of the gut biome and the gut bacteria might have to, and that's relationship to the brain. So there's a lot of ideas, and that's the point of the slide, is that nobody has a singular one bullet solution to Alzheimer's disease. In terms of the pharmaceuticals, on the left side, there's the acetylcholinesterase inhibitors, which, and as well as Namenda, which are the standbys for treatment. They tend to be short-lived. Maybe about 10% of the people benefit from them in some fashion. I usually, when I prescribe them, I remind the patients and their families that they may not make the memory so much better, but they may make the functional status better or maintained, right? So we don't want a decline in their trajectory, and so we want to slow that process down. I'm a big proponent of turmeric for osteoarthritis. There's some evidence that it's the equivalent to Motrin-like or NSAID-type compounds for relieving knee osteoarthritis pain. There is some evidence, but not strong evidence, that it might help with preserving memory function, and not so much no evidence that it's really a treatment for Alzheimer's per se. Just want to mention here about some of the side effects. I think the bottom line here, if you look at the right-hand column, is it's mostly GI distress that's associated with all of these medications. And it's important to avoid, just not only in patients with memory loss, but patients in general. These are unsafe medications, and the benzodiazepines are meant to cause amnesia. So there's both retrograde and antegrade amnesia. Benzodiazepines cause falls. They can cause head trauma from those falls, and they are just the Darth Vader of of all the medication class of medications. Opioids, very interesting research on that. Chronic opioid use can lead to dementing illness, and I think that's important for people on chronic opioids. I had a patient who was on a nightly tramadol to get to sleep with, I guess was her rationale. And I mentioned to her, I said, well, you know that chronic opioid use and things like tramadol can cause Alzheimer's. And I put it in that term, it may not be Alzheimer's, and she says, oh gosh, well, we don't need any of that. And so she decided that maybe the tramadol wasn't so I did not have to re-prescribe it for her. So that was good. The other medications listed here, like the anticholinergics, like Benadryl, or Ditropan, they can predispose the older adult, particularly those with memory loss, to delirium. And so they may be okay on the medication when everything's normal, but then when they get sick, that delirium may blossom as a result of being on these medications chronically. Some of the Parkinson's meds, they're also used for restless leg syndrome. Sometimes those can cause antegrade amnesia, so that's an important consideration. And all the Z medicines, the zolpidem and so forth, we call them the Z medicines. Those are the sleepers. They get you 10 minutes of extra sleep. If you think that's worth it, take them. I don't think they're worth the cognitive dissonance that they cause. So they're sort of subsets of the benzodiazepines. I don't think long-term use of those are valuable for cognitive health. And then I just mentioned amitriptyline is considered one of those antidepressants, and they also use it for neuropathies. That also has anticholinergic properties that are not very good for older adults. So mentioned lifestyle. These are all pretty straightforward in terms of opportunities for good brain health. In terms of clinical approaches, we need to think about the safety of the older adult. First thing is to look at driving cessation, when to take the keys away. Making referrals to occupational therapy for driving evaluation is always a good tool. Asking about the weapons, are there any weapons in the house? And then also going through your checklist, you may use the CDC STEADY program to look for fall prevention. So somebody asked a question earlier, what can primary care providers do for caregivers? And the simple answer is get them referred to caregiver training, whether that be through the Alzheimer's Disease Association. We have a program called CARE in collaboration with the Alzheimer's Association, where our providers can refer caregivers for a 8-session webinars, basically. There's online resources for caregiver training too. Oops. And then again, from a primary care perspective, if you do have a caregiver with you in the clinic, give them some of the tips. Don't be argumentative with the demented patient. Consider respite for themselves as caregivers. Always go with the flow. You don't want to argue. And you want to basically go with the flow and then deflect. Try and get them moving in a different thought process. And, a lot of times older adults, anybody with dementing illnesses can perseverate. They think about the same thing. They keep repeating the same stuff over and over again. And so you try and get them redirected, but not in a confrontational way. So I want to kind of wrap up my presentation with talking about how to approach quality improvement. And that this is the basis. The plan, do, study, act cycle is the basis by which we improve things. So we look at something and we say, wonder if we can do better with that. And so, for example, it may be in a long-term care facility or in the community where somebody has, falls or a high rate of falls. And so we get together as a group of healthcare providers and maybe even, the long-term care residents and say, what do we know about fall prevention and what can we do about it? And so one of them may be doing stand-sit exercises 3 times a day. So that may be the quality improvement plan. And so you do that, and then you look over the next month to see how many falls there were. And actually you have to be maybe after 2 months, because it takes 4 to 6 weeks for any type of musculoskeletal intervention to really take effect. So this is just the approach that you take. And so you may want to, you may have read an article, right? So somebody says, interesting article here that shows that you can prevent falls by giving vitamin D. And so then maybe everybody in the long-term care facility or assisted living facility should think about, taking regular vitamin D, daily levels, and then see if the fall rate changes. So here's an example of dementia-friendly improvements. So there's just a simple question. The study was done a couple of years ago, and it was pre-pandemic, and it was asking the question that, what about the annual wellness visit or the annual wellness exam? And so by bumping up the annual wellness exam, they found out that the detection of memory loss was much better than when they were just doing it regularly in the clinics. So that this was a particular type of intervention that led to increased recognition of the condition through improving the uptake of the Welcome to Medicare exam or to the annual wellness exam. Interestingly, one of our partners, just to mention, as a quality improvement project, they give little tickets to their patients to say, please take this to the front desk so they can schedule you for your annual wellness exam. Because as it turns out, people don't normally ask for the annual wellness exam. Even in my clinic and at Sanford Fargo, we've sent out birthday cards saying, please schedule your annual wellness exam. And they like the birthday card, but they don't always follow up with asking for that annual wellness exam. So we have to catch them while you can, right? So if they're in the clinic, you give them the little ticket, and they get, the clerk then signs them up for their next visit. So if you do quality improvement, you want to do something what's called the run charts. And so over time is on the x-axis, and on the y-axis will be whatever parameter you're measuring. So it may be the rate of falls. It may be behavioral changes using the neuropsych inventory test in a long-term care facility. And you want to see how that score changes over time. And you can see at the top here, the scores aren't changing very much, and probably this intervention that you plan really isn't working. But then if you go to the bottom, you can see that there's improvement in the metric that you're looking at, or the indice. And so this would be something that shows improvement, and you more than likely will want to adopt it as a regular practice in your clinical activities. So just some quick ideas, for quality improvement in dementia care. So one of them is, can we increase the detection and documentation of dementia in the clinic? You might have 5,000 patients in your clinic. That based upon their age distribution, that at least there should be around 10% prevalence rate. And so you could check to see how close you are to that, and how many diagnoses are actually in the patient's charts for dementia. One of the other ideas, which we've trialed and found successful, is to do group visits through the patient-centered medical home. And we were doing caregiver training. And so you can ask the question, is there less caregiver burnout as a result of group visits for caregivers? And likewise, just going down the list here, a fall reduction program. Somebody could look at whether turmeric itself reduces discomfort in dementia patients. So one of the empiric treatments for agitation and dementia in long-term care, for example, is to empirically give Tylenol with the presumption that they're experiencing pain. So that's a first level intervention that's been advocated by the British Geriatric Society. All right, so then the next part is I just want to summarize. Just remember that dementia, whether you have a normal screening test, the patient still can have dementia, as defined by loss of executive function. And it's important from the clinical setting to not only talk about changes in memory, but also addressing the functionality, both physical functionality and psychosocial functionality. In terms of the physical exam signs, I mentioned about the frontal release signs, the cogwheeling are important, and the vibratory sense. And then finally, just to always consider yourself as a quality improvement officer, no matter whether, what end of the healthcare team you're on, that all the team members should be thinking about quality improvement measures.